My name is Alexandra and I'm a nursing student at the University of Michigan. My clinical placement was at the Glacier Hills Rehabilitation Center. I'm going to present a patient to you. The patient interviewed is a 74-year-old married white male. He was formerly a teacher at the Washtenaw Community College. He has been retired for the past 10 years. The patient's chief complaint is shortness of breath upon exertion and fatigue. The patient cannot walk more than 10 feet without getting winded and cannot perform the daily activities of living. About 3 months ago, the patient suffered a tight burning sensation in his chest, accompanied by chest pain, severe fatigue, and shortness of breath. This was thought to be a cause of acid reflux. On December 15th, the patient was admitted into a local hospital and upon examination was referred for surgery. The left side of his lung was damaged due to his COPD and needed to be surgically removed. The patient also had coronary artery bypass surgery due to plaque buildup in the walls of his coronary arteries because of his coronary artery disease. The replaced vessels or grafts were taken out of his left leg. The patient was sent to Glacier Hills Rehabilitation to recover and rest from his 2 previous surgeries. His condition affects his daily activities, such as taking care of his wife, who is his source of stability. She, too, is recovering at the same rehabilitation center because of cancer. The patient's vitals were not taken, but they are probably higher because of his conditions of COPD and coronary artery disease. His blood pressure would be higher than the normal 120/80, closer to 140/80. He would have a faster respiration rate, over 20 breaths per minute, higher pulse rate, over the 100 beats per minute. Temperature can be estimated to be around the normal 98.6 degrees. General assessment. Patient describes that he is not satisfied with his health and is tired of having to rest all the time. He has a low energy level, does not experience fever, chills, or night sweats, has excessive fatigue that interferes with his daily activities. He does not report heat or cold intolerance. Functional assessment. Patient does not consume alcohol, does not smoke, or does not abuse drugs. Patient does not exercise and moves around little since he gets short of breath very often. He is trying to get his rest and to get his strength back. He sleeps on average of 10 hours per day, sitting or laying in bed for most of the day. He often has trouble sleeping, so he must take a sleeping pill before bed. Does not eat regularly, or does not have much of an appetite. He does not drink caffeine. He uses his inhaler twice a day and remains on the oxygen tank for most of the day. Past medical history. As a child, patient experienced problems with asthma and bronchitis. Asthma has been induced by exercise. He outgrew the asthma, but it came back during his time in the war. He is up to date on all of his immunizations. Patient is allergic to mold, dust, tape, mildew, streptomycin, and lidocaine. Past hospitalizations. 4 years ago, the patient had a hip replacement. Current medication that the patient is taking pertaining to his diagnosis are the following. Lasix, 40 mg tablet taken 1 time per day, treats fluid retention and is taken because of his coronary artery disease. Metoprolol, 25 mg day tablet, beta blocker that is used to monitor heart rate and blood pressure. Omeprazole, treats gastroesophageal reflux disease, taken twice a day. Crestor, 20 mg tablet taken twice a day to treat high cholesterol. Nitroglycerin, tablets used to treat angina. Spiriva, inhaler that is used to prevent bronchospasms in those that have bronchitis. COPD or emphysema. Symbicort inhaler, 160 over the 4.5, 2 puffs taken twice a day. Psychosocial data. Patient has very close relationship with his grandchildren, children, and wife. He was raised Protestant but is not currently practicing any religion. Patient is educated and graduated from University of Michigan. Does not experience any stressors anymore. Family history. Reported that both mother and father had respiratory problems. First review of systems. Cardiovascular. Patient currently has no chest pain, arm, or jaw numbness. Has had no history of heart disease and has had no murmurs. Can walk only a few feet before becoming distressed and short of breath and needs to bring the oxygen tank with him when he is walking. Patient cannot lift more than 10 pounds. Patient has difficulty breathing when he is lying flat and needs to have 2 pillows propped up to elevate himself and make it easier for him to breathe. Second system. Given the patient's diagnosis of COPD and recent lung surgery, it is important to assess lung function and capacity. Lungs and thorax review of system. Patient experiences constant shortness of breath all the time, even while sitting down. He experiences shortness of breath when he has to get up, particularly. Uses a spirometer so he can breathe better. When he coughs, it is productive. Sputum consistency is thick and varies in color. Coughing leads to clearing of his airways and is encouraged. Patient experiences no pain or wheezing while breathing. Presently has no chest pain. Chest pain is most commonly experienced when he has to get up. When asked to rate his pain, on a level of a 1 to 10 scale, he responded a 3. Respiratory examination. Upon respiratory inspection, visual shortness of breath, especially in exertion, is seen. He has a barrel chest. Pursed lip breathing, use of accessory muscles while breathing. Patient has no cyanosis or signs of skin discoloration. No clubbing of fingers. Visible scarring on chest from past 2 surgeries. Upon palpation, no tracheal deviation is present. Patient has decreased chest expansion and decreased tactile fremitus. All ribs felt are intact. Upon auscultation, decreased tactile fremitus and negative vocal fremitus were found. Soft crackling noises may indicate fluid buildup in the lungs. Quiet expiratory sounds heard throughout all lung fields. Wheezing heard. Cardiac examination findings. Upon inspection, no heaves, lifts, or thrills visually seen. However, can visually see the patient breathing deeper and chest rising and lowering faster than usual. Upon palpation, no abnormalities noted when palpating the 5 key areas. No heaves, lifts, or thrills felt. Atrial pulse may be irregular. Upon auscultation, S1 and S2 sounds present while auscultating with the diaphragm. Irregular fast heart beating. While auscultating with the bell, abnormal heart sound S4 was heard. The sound coincides with the patient's coronary heart disease. No murmurs were heard. Pertinent System 1. According to the 2010 article by the European Heart Journal entitled The Management of Combined Coronary Artery Disease and Peripheral Vascular Disease, the presence of coronary artery disease and peripheral vascular disease is common, and if found together, it increases the risk of mortality by 7%. For this reason, a peripheral vascular examination should be done on the patient. Also, because of the patient's condition, he is most likely immobile, because doing physical activities leaves him short of breath. This can lead to poor circulation throughout his body. For this reason, it is important to assess his upper and lower extremities for tenderness and swelling. Swelling in the feet and legs may be a sign of heart failure. Fluid in the lungs causes swelling or edema and may be a sign of heart failure as well. Circulation can be evaluated by checking the skin color of the fingernails and toenails and the pulses in several locations, such as in the neck, wrists, and feet. Pertinent System 2. Gastrointestinal and nutritional assessment. According to the article Dietary Change, Nutrition Education, and Chronic Obstructive Pulmonary Disease, that regardless of disease severity, weight loss is related to decreased exercise capacity, health status, and mortality, as well as to increased morbidity among patients with moderate or severe COPD. For this reason, a gastrointestinal and nutritional assessment should be performed. Patient stated that he does not eat regularly. This should be a concern for the patient as he does not get adequate nutrition, and patients with COPD need to consume more food because their bodies are constantly working to keep up with demand.